So, apologies if you've done medication training. I'm sure most of you have, because you wouldn't be giving out medicines in care homes if you haven't. But we need to cover it anyway, just because I need to be sure that you're aware of everything. So this session then looks at understanding why medication is necessary, the importance of maintaining service users' privacy, independence and choice and consent. Be aware of the legal surroundings around medication management, become familiar with your organisation's policies and procedures, to know the role that you play in giving medications, be aware of your boundaries when assisting with medication, and to understand what you can and cannot do in relation to medication. So, a couple of the legislations, and again in Canvas, at the very first app, I've given you all the laws here, but you need to be aware of the Medication Act 1968 as amended. So that talks about the categories of medication and what is and is not considered to be medication. The Misuse of Drugs Act 1971 looks around controlled drugs and how drugs are used in medicine and when we cannot use them. Obviously, the Health and Safety at Work Act 1974 looks at providing safe working environments when administering medication. CQC have their own guidance on this as well. The Management of Health and Safety at Work Act Regulations 1999 looks at the employer's responsibilities in providing safe environments. So that's things such as medication rooms, dispensing trolleys, and all of those things that you would expect there. Because you're giving out medicines, it is a substance hazardous to health. So therefore it falls under the COSH guidance of regulation medication. And equally, the Human Medication Regulations 2012 looks at how medication is given to humans and trials of medication and things like that. Equally, we have other laws that there are just some of them, such as the human right laws, the right to deny and refuse treatment and care. We've got the Care Standards Act 2000. So the Care Standards Act for us links in with CQC when they did their changes for effective, safe and more led, when they brought in the Chloes. We have our Health and Social Care Act 2008, and I think that was amended in 2014. Yeah, it is, because it's straight underneath. So in there, you're looking at legislation relating to how medication is prescribed and given in a work environment. We're not going to cover those ones because that's not us. Access to Health Records Act 1990. So that's when Freedom of Information Act came out, where we could obtain records to see our own things. And now the NHS have obviously brought out the NHS app, where you can see all your own medication now on your NHS app, and you can see all your prescriptions, which is right to know. Data protection was superseded by the GDPR regulations 2018, so that's fine, we know about those. The Waste Management Regulations 2012 looks at how we dispose of chemicals, so as in the fact that we need to return them back to pharmacists, etc. Then you've got your home's policies and procedures. So around your home's policies and procedures, this is again another activity that you need to do. So you need to find a copy of your home's policies and procedures for medication. You're going to have to review them, and then you're going to have to make recommendations for an improvement on them. Because this is level 5, you're expected to be able to find your home's policies and procedures for medication, review them to see if they're fit for purpose, are they localized enough, do they explain everything, and then identify any recommendations in which you think should be added to the policy. Okay, so when I come out to see you, I will ask to see that evidence. I'm going to ask to say, look, can you show me a policy that you've reviewed and that you've amended? Now, obviously, I don't expect you to change culture in your place of work. That's not what this is about. It's about a learning activity to show that if you were responsible for a ward or you were responsible for a home, you would be responsible for the policies and procedures. So you're able to review the policy, come up with some recommendations, and that's all I'm looking for there. Obviously, your policy and procedures covers the types of medication. So are you aware of all your policy and procedures around normal handling of medication, homeo remedies, and also controlled drugs? And again, different homes seem to have different policies around controlled drugs. So there is a lot of debate in the world about what controlled drugs are, what should be on them, what shouldn't be on them. So in some homes, I see things like diazepams and all of those under controlled drug medications, and in other homes, they're not. No. So it just depends who's writing the policies up and how strict your home is on what they constitute as controlled drugs. Obviously, over-the-counter medications, your home, your remedy stuff. So how do you manage that in your place of service? Are family members allowed to bring in paracetamols and throat lozenges and aspirins and all of that stuff and give them to relatives? Or have they got to give them to you for you to give? Are they allowed to manage their own homeo remedies? So what's your policies on that? Obviously, PPE regarding medication, rules of admission and procedure requirements, routes of admission. We're going to follow those normal things. Your roles and responsibilities looks at the prescribing and the dispensing. So when we talk about prescribing, so obviously you're not prescribers of prescriptions, but you may be prescribing homeo remedies. So for example, if people aren't going out in the sunlight enough, you may be going, look, you could try a vitamin D supplement. It's an over-the-counter thing. What's your roles and responsibilities there? If somebody has a headache, are you able to go, look, there's some paracetamol here? No different to as if you were to go out in the shop. You know, if somebody's got capacity to say, can I have 2 paracetamol? Would you give it? What's the results there? And obviously dispensing, what are you allowed to do in your home? So when we talk about dispensing from a nursing point, we're taking it from a packet into a pot. We're not taking it from blister packs or no med packs. We're taking medication with a label on it, and we are dispensing that in accordance to a mile chart. So that's what we class as dispensing. And equally, if we are dispensing, are we dispensing in front of the customers so they can see what's being dispensed because it's their medication? Or are you dispensing it and just giving it and therefore they don't see what's being done? So how's that being done? Again, we talked about the medical and non-medical route. So under the non-medical stuff, what can you do? Responsibilities for the manager. So that's the CQC compliance stuff. How are you going to conduct your audits? Hopefully in the next week or two, I will have ready for you this book. So this is the advanced course pack for competency assessment for auditing and managing medication incidences. Okay, so I'm going to have this scanned up for you. And in here, it runs through all of the different types of medication, how to conduct audits in line with CQC and the NMC Code of Practices, and how to come up with action plans and stuff. So that's going to be something that'll appear next week. It's a workbook. You don't need to fill it in. It's for you to read, and it's just for help. It's there to help you get your heads around the fact that whilst you've probably all been given medication, you probably haven't been taught about auditing, compliance, CQC regulations, and all that stuff. So it gives you that top-up bit of knowledge which you should have.
Thank you, Stephen.
No worries. You then got social care workers and managers. What's their roles and responsibilities? Care workers, and obviously, if you're dispensing or giving medication, how are you going to get your team to help you? Because technically now, as long as you're trained, anyone can give out medication. But if you've dispensed it, how are you supporting your carers in regards to understand that? And obviously other administration activities. So that's normally stock and order, making sure that prescriptions are being requested and all that stuff. So that's understanding the wider thing. You must be able to talk through prescribing, dispensing, how you give it, how you store it, and how you dispose of it. So when we have the professional discussion, that's what I'm going to be asking you, because it is the end-to-end journey of medication. Okay, so if you're not involved in the full medication cycle, you need to start becoming an inquirer, start asking questions. You know, when it's prescribed, where does it go? How does it get done? Who's dispensing it? When it comes into the home, how am I checking it off? How am I booking it in? Once it's in the home and I do an audit, what do I do if medication is missing? How do I get involved in that? When I give the medication, storing of the EMR charts, what do the EMR charts look like? How are they audited? Storing of the medication, knowing all the different types, and then obviously disposal of that. What happens when the medication has come to its end life cycle? How do I take that out of the system? Okay, because that's the whole life cycle of medications. You should be able to tell me what can be done and what you can't do. And I need you to answer that as an advanced practitioner, not as a care assistant. Okay, so you need to be answering that as if you were a nurse in charge. So as long as you're thinking about, as a nurse in charge, what should I be doing? What shouldn't I be doing? Equally, the induction standards to medication, you need to understand why it's necessary for medication training. You need to realise the importance for maintaining service use of privacy and dignity, be aware of this legislation, familiar with your policy and procedures, the roles that people play, the boundaries, and what you can and can't do. So, under the medication standards, so for CQC, so the Care Act and the Care Act 2020, no, the Care Act 2000, sorry, and the Health and Social Care Act 2014, you are expected to be promoting service users' independence throughout. So if I were an inspector coming into your home, I would say, how have you taken a personal centered approach for each person for their medication? So for example, I would then expect to see multiple ways of medication being dispensed throughout your service. In some of people's homes, they may have, in their rooms, they may have medication boxes where they can do it themselves. In others, it's led by the nurse in charge. And actually, if there's not that differentiation, it's not personal centered, because there must be an ability somewhere for people to manage their own medications. And if there's not, there needs to be a justification why there's not. And again, it could be a doles act. It could be the fact that these people lack capacity, therefore we will always dispense medication. Fine. If that's what's on the LPS on the doles, that's fine. Equally, use of medication compliance aids. So here you could be looking at timers, you could be looking at dispensing equipment, you could be looking at adaptations and adjustments, you could be looking at wider pill pots. So that bit we did around enablement at the very beginning, is there anything that you can bring in under enablement to help them take it? So for example, if they've got troubles pouring water in the jugs, have you got different jugs and water pots, whatever it is, to help dispense? Or have you got different types of nomads and blister pack boxes? Have you got the timed ones that just pop open and they can tip it out rather than ones that they have to push? So this is what we're looking at around compliant, those aids to promote independence. The care worker and personal assistant role needs to be adapted in line with the personal centre approaches, so that care planning part. So for example, you're going to have some where you're going to give it, and in others, you're going to have some that you prompt. Here's your medication, could you take it for me? What we're never going to do, though, is walk away and not see it, are we? So whether we give it to somebody, we're going to observe. If we're prompting, we're observing. But what we can't do is give it and walk away, because then I can't sign it because I haven't seen it given. And I'm hoping we all know the basic rule is if I haven't seen it taken, I don't sign for it. It's as simple as that. We follow the tablet, and until I see you take it, I am not signing anything. And obviously responsibilities. Now, as we go through different classifications of medications, we use different acronyms. So we've got prescription medication, the POMs, we've got pharmacy medication, Ps, we've got general sale listed medication, GSL, so that's what we can buy over the counter. We can buy from the pharmacist, but you have to have consent. We've got over-the-counter medication, we've got controlled drugs, and then we've got homeopathic remedies. So different classifications, different policies and procedures. So your home's policies must address these classifications of medications. So when you look at your home's policy, hopefully in your policy somewhere, it will give you guidance on each of those points. And if it doesn't, your policy isn't fit for purpose. Okay, so you must make sure when you're reading your home's policy, does it cover those points? I'll let you take a picture. Because it's really important. These are the bits that you need to be aligning your policies to, because if we have classifications of medication, how do I know what they are? What's my roles and responsibilities? If I was the nurse in charge, am I allowed to do this? Am I not allowed to do this under each of those classifications? And again, different homes, different rules. Because remember, if you've got capacity, so if you're in a residential service, Things like over the counter, you may have to have the patient with you. If they haven't got capacity, who gives the consent for it? Where does that consent come from and what does it look like? So we know under our medication banner, we then have different types of medication and we use a lot of different types of medication. So for example, we use different ranges of antibiotics. So things for the flu kind of stuff when people have got pneumonia or infections or UTIs, we normally call those antibiotics. And as we go through, we've got different types of medications. So we've got pain relief there, we've got antacids for reflux, psychomedication for mental health. So again, if we know the group of medication, it kind of helps us understand what those groups are and how they come into us. The reality is we tend to specialize in our own area of medication in nursing homes, because actually a lot of your patients have the same conditions, don't they? Therefore, you see the same medication being used quite a lot. So you become almost specialists in your home's medicines. But you must understand, so for example, if I was on, I don't know, amoxicillin, for example, you should be able to say to the patient, this is an antibiotic for your chest infection. You know, you may not understand what it does, as in all the therapeutic benefits, but you should be able to say what it's for if somebody asks you. And if you don't know, you can go to the B&F and find out anyway, because it'll tell you. Different routes of medication. So we've got ingestion, so we take it in through our mouth. Topical, which is creams. We've got instillation there, inhalation, so breathing it in, so like a pump or a spray. Rectum, so obviously up the bottom. Vagina, very clear. Injection, intramuscular, subcutaneous, so like the flus or COVID. And then infusion, it's mixed in with something. So infusion can either go, it's normally in a drip or something, we can infuse something, or other fluids. So we've got different types there. You only have to know the 6 R's, you don't need to know the 10 or the 12, because I know there are different versions of this out there. You've got the 6 R's, there's 8 R's, you may have seen the 10 R's, and there's 12 R's. You only need to know the 6. So is it the right dose? Does the box tally up with the MAR chart? Am I convinced this is the right dose? Is it the right medication? So you're expected to be able to know that that medication is for that condition. Okay, you may not know what it does, but you need to know, is it the right medication? Because if a doctor prescribes the wrong thing and you give it, you are the one at fault, not the doctor. Sucks, that rule, because you're like, well, surely you're the specialist. Yes, yeah, I kind of think that too, but that's not how the NMC sees it. As a practitioner, you are the one dispensing that medication to that person. Therefore, you must know what that medication is and what it does. And if you don't think it's the right one, you absolutely have the right to refuse to give it and challenge it. Yeah, for the right person. So again, ID checks. How do we do ID checks? How do we know I've got the right person?
Date of birth and name.
Yeah, can I have your name, please? So that's one way. What else?
Date of birth.
Yeah, so they can give you some personal data that proves it's them. What if they can't talk or they lack capacity?
Or picture in the
Contraindications.
So you might have a picture. Okay, so in care homes, you're reasonably good at this, aren't you? On admissions, you take a photo, it goes to the EMAR charts, or you print it out and it goes on the charts, and therefore we know. Or I think if you've got the old blister pack stuff, there's a photo of them there somewhere on the MAR chart, isn't there? Let's say you're not in a nursing home. Let's say you've gone onto a hospital ward because you're doing agency work. How would you know in a hospital you've got the right person?
Wristband.
Yeah, wristband. So again, can you confirm? What if you're in hospital and you've got a wristband, but you can't confirm because you haven't got capacity?
You ask for ID?
You could ask for further ID, yeah, if they've got it. Or alternatively, if somebody's known to that person, you could ask them to confirm that it's them as well. So again, let's say, for example, you've got a baby or a child with you. It's unlikely that they're going to go to the baby or child, can I have your name, blah, blah, blah. They'll just go to the parent or the next of kin and say, look, can you confirm this identity? Great. Ultimately, always pick two ways. You know, I know it's them, I know it's not them. So the right time, how long under the right time can you leave a medication before it's now not the right time? So at what time window slot, either side, can you give a medication?
4 hours.
Hours.
Yeah, up to 4 hours. So again, up to 4 hours either side is generally okay, so rule of thumb. If it goes over that, it's then considered a missed dose. We wouldn't give it, that's fine. The right route, so obviously we've just looked at those right routes, and then the right to decline because that's a Human Rights Act. Okay, so nothing too terrible there. Problems when checking the medication. So these are the things when we do those audits that we need to consider. Wrong medication received, painful when that happens, because obviously that's an issue there. Different types of medications received. So we know that medication has two names. It normally has its generic name and then it has a fancy name. Normally, I can never say the fancy name because unfortunately I'm one of those really common nurses that can't speak Latin. So normally I can only call it the generic name. So for example, if we look at ibuprofen, ibuprofen's ibuprofen. It gets called everything from Nurofen to all the other stuff. At the end of the day, it's ibuprofen, you know, and there's things like, for example, with what my little boy has, he has a drug called levastatin something or other, and I can't say it properly, but the short name is Kappa. I can do that one, I just can't do the big one. There's no rule that says you have to call the drug by what name, but just be mindful that most drugs have two names. One you can normally say, the other one you normally can't, as long as you can name it by one. It doesn't mean it's wrong. So like Ventolin, for example, is known as salbutamol. It's still Ventolin, it's just got a different name. Wrong dose received. So again, checking the doses. If the dose is wrong, then obviously it can't be given. Different from the medication received, as in from a liquid to a tablet. Insufficient medication received, so stock count's not right, or additional medicines received, but not in the usual compliance aid. So it's in the different dosage box, or it's in a box and not it's in the packet. The problem with all of these checks are, if there is an error, you are meant to refuse it and return it and have that error resolved. Now that in itself can cause complications, because if these are drugs that people need because of medical conditions, then that causes certain risks. So it may be the fact that you need to ring up and get consent. So for example, if I was on a hospital ward and I needed this drug, let's say it was warfarin or something, a medication for dealing with blood, I would ring the pharmacist and say, look, this is the error. Can I give this, or should I wait for the replacement? And then they would give me the advice. They would say, look, we were out of stock. You just need to give 2. What they would then have to do is come back and alter the MAR chart. So if they're saying that the medication is different for a reason, the pharmacist has to change the MAR chart. Yeah, so it may be you were taking 2 tablets of 25 mils, but now you've got 1 50 mil. So you're still getting the same dose, but because the chart doesn't tally up, it would be seen as a medication error. So what they would have to do, they would have to come, green pen, normally it's green pen, rewrite the MAR chart, and then it's good to go. If it's a paper chart, obviously if it's an electronic one, they would do the audit chart and then that would be done. But we, as far as we're concerned as nurses, if there is a problem, we don't give it until we've been given consent. We don't assume that's what it is, we just correct it. Preparing to administer medication, same old, isn't it? We've got to make sure we've got our MAR charts, so the medication administration records, washing hands, PPE records, fluids and pills. I'm not going to make you wash your hands. I'm going to watch you do that when I come out, so you all know your 7 steps there. So we're obviously going to look at the MAR record chart, and we're going to make sure that we can A, read the chart, and B, the chart tallies up to the medication. If we can't read the chart, we refuse. It's as simple as that. So unfortunately, doctors and pharmacists get a little bit humpy at this point, but it's simple. If I can't read it, I can't dispense because it's not safe. So they should be doing block capitals when they're writing, and they certainly shouldn't be doing joined up writing or doctor handwriting where it looks like the spider died and crawled all over the page. It's simple. If you can't read it, we don't give it. We must have the name of the medication, we must have the dose, we must have the frequency, and we must have the times. And we must be able to track all of that. When we give medication, it's the non-touch technique. 2 reasons we're non-touch technique. 1, because of infection control. 2, because if I touch medication, I can absorb it through my skin. And therefore, if I'm touching lots of tablets in a day, by the end of the day, I could have a nice concoction of meds. Eye drops. So if I'm going to dispense eye drops, we're obviously going to sit the person down, tilt their head to the uninjured side. The drops go in so it doesn't cross the eye, it leaks away. And eye drops have normally got a 28-day shelf life, haven't they? So once you've opened them, you should be writing on the box when they were opened and then keeping an eye on those.
Stephen, they normally go in the refrigerator, don't they, the eye drops?
Yeah, most of them do, yeah. So again, just store it in line with guidelines. Again, same for the eardrops, same thing. Topical creams. So topical cream, pea-size amount, because a pea-size amount is seen as the dose. Okay, so when it says apply topical cream, it is the size of a pea. Okay, anything more than that, you're applying too much. Okay, so creams are meant to be that amount, and obviously you'd wear your gloves and rub it into the surface. Inhalers, patients should obviously be sitting, they shake it, pop it into the mouth, and they pump and breathe it in. And I'm sure you've all given out inhalers in your times, haven't you? If you do have inhalers, or other things, then spacers normally work quite well. So a spacer is just they can breathe it in and they can inhale it when they want. The benefits of a spacer is it stops the mouth from drying out, it stops thrush on the mouth, and obviously they can breathe it in, so it's inhaled better than it being sprayed into the mouth. Reporting and seeking advice. So you've got your reactions to medication, which is normally the yellow form on the BNF. So have you heard of that? No. Okay. So if you have an adverse reaction to medication, you need to complete a yellow card. And what the yellow card does is it forms BNF, and it forms other people of side effects. So you know when you get that sheet of all common side effects on a leaflet, and it says this may cause 1 in 100 people back pain, or 1 in 100 diarrhea, or 1 in 100 this. So when you get that on a medication sheet, it's come from what's called the yellow card. And the yellow card is down to healthcare professionals to fill in and inform drug suppliers and people with common side effects. So if you observe an adverse reaction, then you would do a yellow card. How long is it normally before you would see an adverse reaction? So once I'm given a tablet, what's the average time for an adverse reaction?
1 day.
No, a bit sooner than that. But
Is it an hour?
no, a bit sooner than that. Think of COVID-19.
15 minutes.
There we go, 15 minutes. So what we know is normally, once we've ingested medication into the body, if I were to have an adverse reaction, it would happen within the first 15 minutes. So actually, if I've passed that time, I'm generally okay. We'd obviously seek advice around refusal to take medication. And this is because we enter that really grey area around capacity and consent. So even though we have the right to refuse, do we have the right to refuse? So have we got an LPS? Have we got a DOLS in place? Are we under a 135 from the courts? Are we under a treatment order? Do we have to give that medication? And if we have to give the medication, how are we going to give it? So are we going to give it by force? Is it going to be an injection? Or are we going to find another way of doing it? So people have the right to refuse, but there are some people that don't have the right to refuse. Normally all under the mental health grounds, normally all under treatment orders, and if they're under a treatment order, they can't refuse to take that medication. It's part of the law. The law says you must take this to be compliant. And obviously, we need to make sure that if they are refusing medication, that we're reporting it, because if it's things for their health and they refuse, it could come back as neglect on you if you haven't reported it. And equally, you may find that some of your patients over time start to go, oh, I don't want that one, I don't want that one, I don't want that one, and they're refusing the same tablets. So at that point, you might as well do a medication review, because if they're never going to take it, there's no point it being there, is there? Errors in medication obviously will have to be reported. If you had an error in medication, so you either overdosed or underdosed, what would you do?
I never had, but I saw someone.
Yeah,
And they've called the doctor. They just give to the wrong person.
yeah,
They called the doctors and they said to monitor all day long, to take the vital signs, to take blood pressure, and just observe.
yeah, perfect. Yeah, and that's about right. If you've overdosed somebody or underdosed them, normally the advice is observe them, do the vital signs, see how they're going, look for adverse reactions. However, there are some medications that if you did overdose on, it could be life-threatening. So again, you just want to make sure that you've crossed all the I's, dotted all the T's. No, that's not right. Dotted all the I's, crossed all the T's, sorry, and made sure that you've done your duty of care, and obviously everything prescribing. Right. So medication, your MAR charts, this is typically what they look like. The electronic ones I know are a bit more fancy, but ultimately up here you've got any known allergies. Normally allergies are in red. So I think even on the electric ones, they come up red, don't they, if they've got known allergies. And in there, it obviously gives the doctor's phone number. So if you did overdose or underdose, you know who to call. It gives you the start time, the end time, who the doctor is. And the reason you've got your doctor's name and telephone number on there is so you're not wasting time. Okay, because nobody wants to go to an office and find out who the doctor is and you can't get hold of them. And obviously then whoever's responsible for those, filling them in. Now at the bottom, you've got your key codes on your MAR charts. So you can see if it's refused, it's normally an R. If they're sleeping, S, D for destroyed, N for nausea or vomiting, and O for other. So under O for other, what other things might be we recording on a MAR chart? So you've got refused, they're sleeping, you've binned it, or they've thrown it up. What else could there be for other? Oh, Karina, you're on silent, and Theodore, you're on silent.
Out of stock.
Okay, so out of stock, yeah. So
Yeah, no.
it might be the fact that you've run out.
Out of date.
Waiting for the pharmacy for delivery.
Yeah, waiting for the delivery, dropped it, all of that stuff. So that's all going to be on the other. Now, if you're going to do other, normally on the back of the MAR chart, you've got a log, haven't you? So you would then write what that other was. Okay. Medication and storage. So we know, obviously, all medication labels must be electronic. So we're not allowed to accept handwritten ones, and clearly must have the dose, the name, the amount, the volume, how it is stored, their name, and the expiry date. So that's what needs to be on a label. So in there then, if we said should be an ambient temperature, what's an ambient temperature?
I think 5 degrees.
So ambient temperature is normally your room temperatures.
Oh, okay. I think it's
18 to 27. So,
Close, close. So 15 to 30 is your ambient room temperature.
okay.
Yeah. So if it says store in a cool place is
It's 2 to
5 normally.
Yeah.
Yeah, which is your fridge. So your fridge is normally between 0 and 5. But in a cold place, it's not necessarily a fridge, but it's not necessarily room temperature. So it's just a coldish place. So again, just make sure that your policies list this, because again, you could say, but I thought a cold place was a fridge. Now, a fridge might be too cold. So if it says a cool place or a cold place, what does that actually mean? Does that mean stick it in the fridge? Does it not mean put it in the fridge? If it says ambient, does ambient mean the same as room temperature? So again, in your policies, there shouldn't be any ambiguity. It shouldn't be confusing. It must be, well, what does this mean? Is it very, very clear? Again, for the disposal of medications, we've got to make sure that the policy tells us clearly about assisting with the disposal and what to do with the medication when a service user dies. Okay, so when a service user dies, what are we doing with the disposal? Or what do we do with if it's just overstock and stuff? A lot of the chemists will take it back. Some of the chemists they tell you to destroy it and just to report it. So the problem is when you destroy medication, where do you put it?
We don't destroy, we just return it to the chemist.
Okay, so you're going to return it. So a lot of the places, the pharmacy will say you can destroy it. But for you to destroy it, you must have a certain box to hand. Have you heard of the Doom box? No? So if you have a Doom box, you can destroy your own medication. And what a Doom box is, it's a plastic container, but it's got like a gelatin in it. And basically you can put the capsules in there and it destroys it. So a Doom box is a way in which you can destroy medications. All hospital settings have them. And a couple of the services that I've been in, larger care homes have Doom boxes or Doom kits. And what a Doom kit is, you can drop it in and basically it destroys it. So things like controlled drugs or insulin, you can tip into a Doom box and it basically makes it unusable. Okay, and it's a safe way because it hardens up and then it's no longer dangerous. But we certainly don't put them in the bin and we certainly don't flush them down the drain. Okay. Your policy as well obviously needs to cover consent. So what's consent look like? I know a lot of you will have the covert policies in there. So obviously covert's when we hide medication. And obviously you should know what to do with your pharmacy there. Okay, so in conclusion there, we've looked at different ways of service users' independence. So each service user must have their own medication risk assessment. So it's the risk assessment around, do they have capacity? Are they able to do this themselves? Do they take it with prompt or do they take it if I give it to them? What happens with capacity? Are they able, do I put it in their hands and they can do that? Or have I got to put it in their mouth? So that's what the risk assessments adjust. We've looked at the classifications of medications. So you should all know how to get your medications, what you're allowed to do, what you're not allowed to do, differs from home to home, place to place. We've looked at different types of medication. So again, your policies in your workplace should be very clear about what a controlled drug is. We can't just assume that just because it has CD on it, well, if it has CD on it, it is a controlled drug. But some services list other controlled drugs as controlled drugs, even though they're not controlled drugs. It gets very confusing. But what you should have in your medicine room, on that door, you should have a list of what your controlled drugs are. Now, if you have controlled drugs, what is the policy for that controlled drug? Are two of you dispensing it? Are two of you signing it? Are two of you watching it? And are two of you going back signing the book to say that it's been given? Or are you dispensing it and then one person's given it? Which I hope that's not the case because it should be two to follow the drug.
Yeah, 2.
But a lot of the time when I see it done, one nurse does that you go together in the medicines room and then the nurse just goes off and gives it by themselves. And actually they shouldn't be doing that because if they gave it to the wrong person or anything like that, they've breached the medication policies. Different routes. So again, different routes, different reasons. Why can I give this? How can I give this? Different indications. So side effects, etc. Risk assessments we've talked about. The 6 R's we've looked at and checking medication. We looked at common problems. So we looked at medication errors and overstocks, understocks, etc. Preparing the medication to be administered. So checking the MAR chart, making sure you've got the right person, right dose, right place, etc. Administering the medication, making sure that you've got the right equipment, and that people are able to do it. Report and seek advice. So if you overdose, underdose, we know what we're doing there. Recording, obviously updating MAR charts and the stocks and things like that, making sure it's all stored in the right place. Doing your audits and stocks. And like I've said, I'm going to scan this up. There's just one little activity at the back, but this is a really useful course. And like I said, it's the complete competency assessment for medication. And then at the back, I've also got a short workbook in there for you if you give warfarin. So if you've done warfarin or you give warfarin, there's a little workbook in there as well for those that do warfarin, because again, different policies around warfarin there as well. But that's just for your extended reading. Okay. Any questions on medication? I feel like I went through that quite quick. You've all done medication training though, right?
Yes.
Yeah, good. So really, this is just a top up anyway. The reality is online, there's a video for you to watch, which is your normal medication training. And equally, you would all have been observed, given medication, I assume, and you've all had your competencies done?
Yes.
Yeah, okay, good. So equally, you know, if you were to then support a junior member of staff, you would do the same training with them, run through everything, and they would be observing you and you would be observing them, and you do that cross-check stuff. Yeah, happy with that? Marvelous. Okay. We're not going to do all those activities. That's that one. Right. Now we're just going to move into slide.